All right, great. It looks like everyone is here who's going to be here. So welcome, everyone. Thanks for coming out on this beautiful Tuesday night in New York City. My name is Andrew Reidenbach. I am a psychotherapist and outreach coordinator at myTherapyNYC. And I want to welcome everyone to our Exploring Different Therapeutic Treatment Modalities tonight. Very excited to have you all. We have therapists from both myTherapyNYC and MindWell. So myTherapyNYC, we're a group private practice in the Flatiron District. We're an LGBTQ affirming practice, and we specialize in relational therapy and EMDR. We offer individual, couples, and group therapy. And then MindWell is a group psychology practice based in Chelsea. They specialize in cognitive, dialectical, and mindfulness-based behavioral therapies and are committed to providing culturally responsive services. They work with children, adolescents, and adults and offer individual, couples, families, and group therapy. And tonight, our panelists are going to be Jonathan Basla, Madison McAllister, Dr. Rebecca Berger, and Dr. Kylie Callahan. So we're going to start off with some introductions. So Jonathan, could you tell us just a little bit about yourself and then also just name the therapeutic modality you're going to be discussing tonight?
Sure. Thanks, Andrew. Hi, everyone. Glad to have you here. My name is Jonathan Basla. I'm a mental health counselor with my limited permit, and I'm a therapist at myTherapyNYC. I work with both individuals, couples, and I also run one of our gay men's groups at the practice, and I will be covering relational therapy tonight.
You muted
yourself. You're on mute, Andrew.
You think after 2.5 years of doing this, I would know what I'm doing. Sorry about that. Thank you, Jonathan. So next up, Maddie, same question. Could you just introduce yourself, tell us a bit about yourself and which modality you'll be speaking about tonight?
Yeah, so I also am a psychotherapist at myTherapyNYC. I'm a social worker, psychotherapist, and tonight I'm going to be talking about EMDR therapy, which I'm trained in as well.
Awesome. Thanks, Maddie. And then next up, Rebecca, if you haven't guessed it, could you tell us a bit about yourself and then also which modalities you'll be discussing tonight?
Absolutely. Thank you. I'm glad to have everybody here. Like Andrew mentioned, my name is Rebecca Berger, and I'm a licensed psychologist, and I'm also the clinical director at MindWell NYC. And I'm board certified in behavioral and cognitive therapies, and I specialize in using various behavioral interventions such as ACT, DBT, and exposure therapy to treat a range of mental health issues. And tonight I'm going to be speaking about CBT and ACT therapies.
Thanks, Rebecca. And then last, but certainly not least, Kylie, could you tell us a bit about yourself and also which modality you'll be bringing to us tonight?
Sure. Thank you so much for having me. My name is Kylie, and I'm a postdoctoral fellow at MindWell. I primarily work with adolescents and young adults and specialize in CBT and DBT. Tonight, I'm going to be talking about DBT, which stands for dialectical behavior therapy.
Awesome. Thank you so much, everyone. And for those in the audience, I feel like we just threw out a bunch of acronyms and you're probably like, what is happening? Which is which? But that's exactly why you're here. So now we're going to dive right in and learn about kind of what are these modalities, what they're used for, what they're not used for, and hopefully you can walk away with a greater idea of these ways of doing therapy. So to start off, Jonathan, you said you were going to be speaking about relational therapy. So kind of three-part question for you. Can you explain what it is, what it's used to treat, and then also about how long treatment typically lasts?
Sure. Yeah, happy to tackle the three parts. So relational therapy, what is it? As you can kind of guess from the name, relational therapy is a therapeutic approach that focuses on relationships, both inside the therapy space or virtual therapy space and outside relationships as well. Often we think about relationships in a few different capacities: romantic, friendships, family, etc. However, we deal as humans with different interpersonal relationships every single day: colleagues, neighbors, interactions in stores, coffee shops, and more. Through relational therapy, you can explore how mutually satisfying relationships can impact one's emotional well-being. This is true for the relationship between you as a client and the therapist as well. So through the safe bond and secure bond that you can create between the therapist and the client, we can find healing and positive change occur. Relational therapy takes into account the intersectionality of all parts of the person. So race, gender, sexuality, socioeconomic status, just to name a few, which can help the client feel seen and heard on a deeper level that they may be lacking in certain areas in their lives. This social and cultural context can help the therapist see how all parts of your life may be impacting your ability to connect with others. In relational therapy, you have the ability to share hidden parts of yourself with relational therapists. So things that might elicit shame or embarrassment or fear of judgment can be brought up in the safe therapeutic alliance with a relational therapist. In relational therapy, you can explore discomfort and or conflict within the therapeutic relationship, which can lead to healing and repair in other relationships. Often you find in relational therapy, which is true for other modalities as well, a level of empathy and attentiveness from your therapist to you as the client. Certain part of relational therapy that might be different than some other ones that we cover tonight and others in general is that a relational therapist may self-disclose how they're feeling based on what the client says and check in with the client to see what they're feeling based on what the therapist shares with them. So you may share as the client that you're going through something difficult or there's a challenge, and the therapist might express some sadness of their own or maybe some anger that's arising within them. And then check in with you and meta process what it's like to hear and know that the therapist, this person that is there for you in the present, is feeling a certain way so you can connect and share on that emotional level. Relational therapy can also help with breaking down conflict and creating bridges towards better communication to repair those ruptures. This can help you to be better understood in those around you and also honoring your authentic self. One of the relational modalities we actually practice and specialize in at myTherapyNYC is a modality called AEDP, which stands for Accelerated Experiential Dynamic Psychotherapy. This was created by Dr. Diana Fasha, and some of the things that can result through AEDP trained therapists is undoing aloneness, again, both within the therapeutic space and in outside relationships and your whole being in life. A focus on the here and now. So often with a relational therapist and one that practices AEDP, they're often going to bring it back to what's happening in the room, what's happening between the client and the therapist in the immediacy of it all. AEDP therapists are also going to privilege the positive. So although therapy for some may seem like a place to reflect on challenges, process, explore some more difficult situations, relational and AEDP therapists are going to bring it back to highlighting maybe what is working. So often we can get stuck in negative feedback loops or cycles where we're stuck in darkness or depressive episodes or anxious symptoms. And a relational and AEDP therapist is going to remind you of those moments and glimmers of light. And overall, relational therapists and AEDP therapists are going to stay curious because we're constantly trying to fully understand your experience as the client and the different parts of your identity that make you up, that bring up your circumstances, your lived experiences, and again, those deeper emotions that we're always trying to tap into, those core emotions. In terms of what relational therapy can treat, relational therapy is wonderful to work with anxiety and depression. It works with trauma, both big and little t traumas. So maybe things that are super heavy from our past that we're holding on to that we're trying to work through, but also maybe microaggressions or small moments that have happened as a consistent line throughout your life. or recently in a certain pattern. It can help with self-esteem issues, poor body image, disordered eating, feelings around chronic pain, grief and loss, insecurities or stress around dating and sex, family or any interpersonal conflict, helping for you to become more in tune with your body and tapping into deeper core emotions. In terms of treatment length, the beauty of relational therapy is the work can continue on for months or years due to the strong bond that is often facilitated between the therapist and the client. So if you are coming to therapy for the first time or restarting therapy to focus on one issue or one stressor, relational therapy can absolutely work for that. And maybe you do finish your therapeutic relationship after 3 months or 6 months. But many of our clients at the practice at myTherapyNYC, and I can speak for mine personally, once we end up going past the presenting problem of what got the client through the door to start therapy, we find that we expand our work again into the more emotional, the present issues, and constantly showing up for the client as the stable, secure attachment figure in their life so that the therapy continues on as really a grounding force throughout the client's life.
Beautiful. Thank you, Jonathan. That was so wonderful. And one final question for you before we move on is, are there any instances where you would not recommend relational therapy to someone?
Yeah, great question, Andrew. So although, again, I listed a lot of things of what relational therapy is great for, there are a few instances when you might not want a relational therapist. So those that are diagnosed or experiencing symptoms of avoidant personality disorder might struggle with a relational therapist due to the connection and bond that you're trying to build and facilitate in therapy with a relational therapist. And then also, if you're a client looking for a therapist with a more neutral approach, or you're a client looking for a therapist who takes on more of an expert role, relational therapy might not be for you. Although all therapy values the relationship between the client and the therapist, relational therapy places more importance on the therapist's responses, the reactions, and the collaboration between the therapist and the client.
Awesome. Thank you for that insight. And moving
You're
on
welcome.
to Rebecca, you mentioned that you're going to be talking about CBT tonight. So could you tell us kind of what it is, what it's used to treat, and then also about how long someone could expect for treatment? And then also just one reminder to everyone that as we're going through this, if any questions pop up for you, please feel free to drop them in the chat and we'll be sure to address them.
Great. Thank you. It's going to be hard to follow Jonathan, very eloquent when you have so much to say. And so I hope I can do the same. As mentioned, I'm going to be talking about CBT as one of the interventions tonight. CBT stands for cognitive behavior therapy. And many people, clinicians and clients included, commonly think that CBT refers to one type of therapy. In reality, CBT is actually an umbrella term for treatments that look at the relationship between behaviors, thoughts, and feelings. Some commonly known words related to CBT or interventions might be things like cognitive restructuring, which is helping to reframe unhelpful thoughts, behavioral activation, which simply means to help you engage in more activities when being active is difficult for you. Exposure and response prevention, which is what we use for OCD or phobias, sort of facing your fears head on, learning to tolerate that distress. And things such as DBT and ACT, which we're actually going to cover this evening as well. The basic assumption behind CBT is the CBT triangle. And the CBT triangle means that thoughts and behaviors can both impact feelings, and then those feelings can impact thoughts and behaviors, right? So it's all connected, and you have to interrupt that cycle. So the intention of CBT is to try to interrupt that triangle, right? So by targeting thoughts, by targeting feelings, we then, by happenstance, target emotions. So we want to increase helpful thoughts and behaviors decrease unhelpful thoughts and behaviors, and lead to an improvement in well-being because of that. Most of the time, people are coming in because of the emotional piece, right? I'm feeling depressed, I'm feeling anxious, I have a social phobia, or maybe my child is refusing to go to school, right? That's the emotional piece. By attending to the thoughts and behaviors that are shaping that emotion, we can then help improve well-being. CBT also focuses on where people learn certain narratives or patterns of behavior. And it focuses on improving the quality of life in the here and now. So while we're going to be focusing on where you learn things, where things were modeled for you, our hope is to improve your well-being in the here and now and the present, and focus a bit more on the present than on the past, while recognizing and validating that our pasts really shape us, right? We're all influenced by our social world, and sometimes we don't even realize where or how we learn certain beliefs or coping strategies. A CBT therapist wants to help you build insight into this while also helping you set goals for both inside and outside the therapy space. So you may have, I don't really like to call it homework because it sounds more negative, but you may have certain therapy assignments outside of the therapy space in CBT. So for example, if somebody is working on social anxiety, we may set a hierarchy of goals for you to be approaching and practicing both in the therapy room and outside the therapy room between sessions, so that you can learn to generalize new behaviors to all parts of your world. A CBT provider may be more active and directive in style because of that goal setting. However, that should never come at the cost of it feeling collaborative and warm, having humor, and meeting the client where they are in their unique experience. CBT done well and not too manualized can be flexible, responsive to a person's need, and there should be a sense of equity in the relationship. CBT can be used to treat like a very, very wide array of mental health concerns. It's not just a manualized treatment for certain disorders. There are specialized types of CBT for many things, such as depression, anxiety, panic, phobias, OCD, PTSD, eating disorders, life transitions, grief, and insomnia, just to name a few. CBT can also be used in couples therapy, family therapy, and most importantly, in what we call parent training. So helping a parent to navigate challenges that come up with children and adolescents. The hope of CBT is to be time limited. However, that doesn't mean we're going to kick you out of therapy after 2 sessions, right? The time could be anywhere from a few months to a few years, and sometimes for some people, an ongoing period of time. However, the main goal is that clients develop enough skills to utilize independently that they can then generalize what they learned and then become their own therapist in real life situations. So once they have done that and report improved well-being over time, treatment frequency can be titrated down. So we might start at weekly and stay there for 6 months, maybe for another 6 months, we'll do every other week and titrate down from there. As a basic rule of thumb, when I'm sharing some information about CBT with people who are unfamiliar, who haven't done it before, I also like to add that CBT research does indicate that clients can start to notice the beginnings of changes in 6 to 10 sessions. And there is a great deal of research on the evidence of sort of time-limited CBT for various disorders and interventions, depending what you're coming in for.
Wonderful.
And I think,
Oh, sorry.
I'm so sorry. Did you also ask when would I not recommend CBT?
You read my mind. That was my next question.
I was getting ahead of myself.
All good.
Okay, well, in that case, so realistically, as a CBT practitioner, my impulse answer is very rarely. However, if I back up and take that into larger consideration, when someone wants to focus more on the quality of relationships, perhaps romantic relationships, friendships, family relationships, not so much because there's certain behaviors or thoughts they'd like to decrease, but they want to explore their emotions around those and what comes up. Sometimes, relational therapy might be a better fit. If somebody has already tried CBT and found it was not a good fit, you don't have to keep going back to the same thing over and over again. What I say about therapy in general is that it's like dating, right? Your therapist and you have to be the right fit. So let's say you tried CBT once, maybe twice for 2 or 3 sessions, and it didn't feel like a good fit. I would urge you to ask yourself, was that because the therapist wasn't a good fit, right? Wasn't a good relationship? Or does the treatment not feel like it was going to meet your needs? Additionally, CBT at an outpatient level is typically once a week. And so if somebody is looking for more frequent sessions, which is more than once a week, more than twice a week, CBT may not be a good fit. And we would recommend a different type of intervention at that time.
Great. Thank you for that insight, Rebecca. And then moving on to Kylie, I know you're going to be speaking about DBT. Can you explain to us what that is, kind of what best it is used to treat like any mental health concerns or conditions, and then also about how long someone could expect treatment to last if they were in DBT treatment?
Sure. So as I mentioned before, DBT stands for dialectical behavior therapy. And this is a treatment that was developed by Dr. Marsha Linehan. And it was initially developed for treatment of individuals with borderline personality disorder, really with a focus on targeting suicidality and self-harm behaviors. Since its development, though, DBT has been shown to be an effective treatment for a lot of other presenting concerns, things like difficulties with regulating emotions, substance use, disordered eating, trauma, and depression. As Rebecca mentioned, like CBT, DBT is also considered a time-limited treatment. And I think what also makes DBT quite unique is that it involves multiple treatment components, which together we might refer to as comprehensive DBT. So those components could include individual therapy, weekly group skills training classes for adults, and then for teens, that would be with a family component as well, phone coaching with a DBT clinician in between sessions as needed, and DBT team consultation. So it's a multi-part treatment. Clients can also be expected to be practicing and working on DBT skills in other settings like work, school, and home. And the hope is they start to sort of generalize this skill use to other settings in various communities. And most often clients in DBT can anticipate participating in a comprehensive DBT treatment for about 20 to 24 weeks in order to complete what would be a full cycle of skills training. And so I'll talk a little bit more about what exactly those skills look like. DBT focuses on 4 major skills modules. Those are emotion regulation skills, mindfulness, distress tolerance, and interpersonal effectiveness. So these skills are effective for things like decreasing confusion about oneself or mindlessness, tolerating distress without making things worse, improving one's ability to regulate emotions, learning skills to sort of get what you want and need in relationships, and managing behavior both in yourself and in others more effectively. DBT also integrates some Eastern mindfulness and Buddhist Zen approaches with those components of more cognitive behavioral therapy. And DBT also really emphasizes this balance between acceptance strategies and change strategies. So the D in DBT, as I mentioned, stands for dialectical. And a dialectic is really a synthesis or an integration of 2 ideas that at the outset seem like opposites. So in DBT, those dialectical strategies both help the therapist and the client to get unstuck from what sometimes feel like extreme positions and to promote some flexibility in thinking. And DBT also requires a behavioral approach. So this means that we assess situations and target behaviors for clients that are really specific and relevant to their personal goals in order to figure out how can we problem solve these everyday problems in their lives and also work towards building a life that's worth living. So that's a little bit about dialectical behavior therapy. And as Rebecca mentioned, it does fall within that umbrella of cognitive behavioral therapy.
Wonderful, thank you. And are there any rule outs or times that DBT may not be the best fit for someone?
This is a great question. And I think the DBT skills themselves that I mentioned are widely applicable and can be so effective for a lot of different individuals across a number of different settings. But that being said, for those who may not be presenting with suicidality, self-harm, other potentially life-threatening behaviors, or a real focus on wanting to improve emotion regulation skills, they may not necessarily be recommended for comprehensive DBT treatment, just given the more time-intensive nature, or sometimes we refer to this as like a higher dosage that's involved in DBT treatment. So of course, it would entirely depend on the patient's presenting concerns, but these are some of the factors that we might want to take into consideration when we're considering making a recommendation for comprehensive DBT treatment versus another modality that could be a little bit more flexible in nature or sort of a lower dose like CBT treatment.
Great. Thank you so much, Kylie. That's so informative. And I'm learning so much from all of you. So thank you.
Thank you.
And actually going back to Rebecca, since I know you're going to be speaking about another modality, so ACT therapy. So same batch of questions. If you could explain to us what it is, what it's used to treat, and then also about how long treatment typically is.
Sure. And thank you to everyone for listening to me speak so much this evening. I've given sort of, a little bit of an introduction to cognitive behavioral therapy, and acceptance and commitment therapy. ACT falls under that umbrella. So as I mentioned, it stands for acceptance and commitment therapy. And I think it's worth mentioning that it's a third wave CBT treatment. CBT, as we refer to it, just when you say like, oh, I'm going to CBT, I'm in cognitive behavioral therapy, right? That's often considered what we call a second wave cognitive behavioral therapy. Second wave CBT interventions look to change unhelpful thoughts and behaviors, and it tends to be more problem solving in its orientation. Third wave CBT interventions, which include, as Kylie mentioned, DBT and ACT, are a bit more holistic. They take the good parts of what worked in CBT and expand it, and they focus more on acceptance, incorporating mindfulness, values and life goals, and building a life worth living. So ACT, acceptance and commitment therapy in particular, utilizes both acceptance and commitment strategies to increase cognitive flexibility. Cognitive flexibility has quite a lengthy meta definition, but generally it means to be in contact with the present moment. So using those mindfulness skills, even in the face of distress, and to choose values-driven behavior despite that distress. So if I say I have a certain set of values and I want to live by those values, how do I do that even when my emotional pain is steering me in the opposite direction from those values, or make contacting those values very difficult? So ACT very much focuses on accepting that to be alive means that we will inevitably suffer, right? That's a basic assumption of ACT. And how do we make room for that versus fighting it, right? We really tire ourselves out fighting that suffering. How do we recognize it, make room for it, come to terms with it? And then once we've done that, then we can do work to identify our values and behave in line with those values to increase meaning in our lives. Sometimes in the face of great suffering, we may not be able to necessarily identify what our values are and how to commit to them. And that is one of the primary goals of ACT. ACT is particularly helpful in addressing rigid cognitive patterns. So maybe all or nothing thinking, obsessions or ruminations, thoughts that feel really sticky and stuck, tolerating intrusive thoughts, urge surfing, which means, sort of what it sounds like. We get an impulsive urge and we have to tolerate it without acting on it. So things included in that ACT can help treat our substance use or eating disorders. Life transitions, including sexuality, gender, breakups, new or prolonged grief, new parenting, lots of life transitions. Persistent mental health concerns that have not responded to other treatments. And those who are uncertain about their values and therefore their goals, right? It can be easy to say, I'm going to set a goal, but how do I set a goal if I'm not really feeling in contact with what my values are and how to sort of increase meaning in my life? A large component other than mindfulness is helping people understand what their values are and how to work towards them. And the cool thing about ACT is that it can be conducted with or without individual therapy services. So you can be in individual therapy with an ACT provider. You can just be in group. For example, I run just an ACT group. So it can be an add-on to other therapy, or it can be the therapy you're in. In terms of length, length is variable as it's more holistic. So it still falls under that CBT guideline that we want really to help somebody be their own therapist in the world. But because it's less specifically goal oriented over time, it's a little bit more variable in length.
Awesome. Thank you. And then just a follow-up question, is there ever a time, or when would be times to accept that ACT is not best for someone? Get the dad joke.
I loved it. I was actually going to comment on that. So excellent. So I find that ACT is really easy and useful to bring into many different types of sessions. So I find that you can do acceptance work or commitment work in CBT and relational therapy and trauma work, right? It's easy to pull in components. That being said, if somebody was struggling with more high risk behaviors, so maybe self-injurious behaviors, high risk suicidality that hadn't yet been treated, substance use that was sort of untreated, right? Like, if somebody had been struggling with this for a while, it was more in maintenance phase, ACT might be a good fit. But if you're coming in with higher risk behaviors off the bat, that's certainly when I would recommend something like DBT first, or if somebody was coming in with PTSD or OCD, I might first recommend treatments that are specialized to that before adding ACT on as an additive treatment.
Great. I love how it can be a standalone or like an adjunct to really any other therapeutic modality. So very flexible.
Absolutely.
Wonderful. And then moving on, last but certainly not least, Maddie, who's going to be discussing EMDR. And I'm so curious about this because I think EMDR has become one of the big kind of new modalities that's really been making a big splash over the last couple of years. So
Yeah.
our audience can't wait to hear more about it. So if you could tell us what it is, kind of just what it looks like how someone might experience it, and then kind of what it's best used to treat, and then how long treatment lasts.
Yeah, definitely. And I'll definitely speak to, it's not a crazy new thing. It's been around since kind of its development in the 80s, but definitely within the last, I think, 10 years, there's been so much more research backing it. In the last few years, it's been backed by the VA for PTSD and combat veterans. And so definitely getting a lot more traction lately in terms of legitimacy and the amazing work that we can do with it. So what is EMDR? It stands for eye movement desensitization and reprocessing. And so it uses a mechanism or a technology that we call bilateral stimulation. And most often you'll see, or kind of like historically, you've either seen a therapist kind of like in session going like this with their fingers, or today when we do it virtually, there's a program we use where a little dot will move back and forth on the screen and you'll watch it with your eyes. In our offices, we also have these little buzzers that are kind of like video game rumble packs that you'll hold in your hands and they'll buzz back and forth. And it's a really kind of interesting technology because what it does is by kind of distracting you with the eye movements or the buzzers, it keeps you partially kind of in the here and now. And also while allowing kind of the more subconscious parts of your brain activate and process trauma. So at its core, EMDR is a trauma treatment. It's developed for big T or complex trauma cases, but really what it focuses on is identifying kind of a core belief that might be associated with a particular trauma. So an example that I like to use a lot with my clients as I'm explaining the process is, say you have a big T trauma event, for example, a car crash, right? One person might experience that car crash and say, wow, that was really scary. I can walk away and I can still drive a car. It might take me a couple of weeks to kind of get back at it. But I know that for the most part, driving a car is relatively safe. Another person might walk away and be experiencing PTSD symptoms. And what EMDR really looks at is kind of the core fear, the core belief behind why that was such a scary event. So one person might walk away thinking, oh, I don't have control. It's really scary because I don't have control over my safety, right? Another person might walk away from that and think, oh, bad things are always happening to me. This must just be another bad thing that always happens because I deserve it, or something like that. And even another person might walk away and think something like, that was my fault, right? And all of those different cognitions can come from a similar event. But really what happens is our background kind of informs why that is getting locked away in such a maladaptive way. So EMDR can be used for obviously big T trauma, small T trauma, but it can also be really useful for things like anxiety and depression as well. When we think of our like very depressive clients, oftentimes they harbor these like very negative beliefs about themselves, like I don't deserve to be happy, or I don't deserve good things. So really what we look at through the process of EMDR is we kind of like surf through our neural pathways and our history to figure out, well, where did that belief start, right? And we sit in the here and now and we get to process, maybe as a kid, I found out this thing that was really something, somebody told me this, and I just took it in and I never thought about it again. And so that's what we look at. It's very interesting. The technology is really interesting and cool. And really, again, it's just about kind of exploring the negative beliefs and where those come from, while also staying in the here and now by using this mechanism of this bilateral stimulation. So all very, very cool stuff. Let's see. Okay. And then your next question was, let's see, how long is this treatment? So definitely was adapted as a short-term treatment. Originally, and I think in my own work, like I've done, knocked out like a small or a big T trauma that was just a single event in like 13 sessions. And that's really exciting and cool work to do. But it can also be a little bit more long-term, depending on kind of the context around the trauma. If it's more complex, less complex, obviously that would make a difference. And then also when you're working with things like anxiety and depression, some of those things can be just a little bit looser and a little bit more kind of like, where did this come from? Or maybe we're dealing with like a handful of negative beliefs. And so in that way, it might take a couple of courses of EMDR to work through that, might take a little bit longer. And then this is also something that with my own clients, like I might be doing regular talk therapy and I might like bop in a couple of the EMDR sessions around a specific belief to work through that as well. But yeah, I would also say there's something called like a recent event protocol. So if you can actually get into EMDR therapy within 3 months of the initial trauma happening, like if you have a big T trauma, like a car crash or something like that, the research shows that the treatment is much, much quicker. And so being proactive about this work can be really helpful as well.
Wow, sounds like a really powerful treatment. You can do some amazing work with it. And I guess given that intensity, are there instances where you would recommend someone maybe not go down this route?
Yes, definitely. So EMDR is definitely, on one hand, it is the eye movement processing, right? But before we even get to that, there is kind of the preparation phase. And so for clients who are maybe in active crisis, experiencing suicidal ideation, severe substance use to the point where like maybe they're, unable to stop using the substances around these EMDR sessions, that would probably not be the best fit for us to like just jump into it. But what I love is that it's kind of a more holistic treatment in that the preparation phase is really just for getting you ready. And so you might really take in a lot of the modalities that were already discussed today to prepare the client to get them in a place where they're stable enough to then do the EMDR, the actual reprocessing itself. So what we want, though, and what we're really looking to get to is a place of stability so that we can kind of go back and explore those things, and you're not going to get super triggered and super activated, so that you kind of can't handle it between sessions. But really, like, the preparation phase and being an EMDR therapist is all about getting your client to a place where they can do that. And then another thing is that it is a trauma therapy, and so it's not super great for things that are ongoing. So if you want like support around dating and relationships, or, you know, a life transition and work, it's not really the type of therapy where you come in on a Tuesday and you like talk about your week. This is definitely deeper work where we're talking about the historical rather than kind of the more present day stuff. Yeah.
Awesome. Well, thank you so much to the four of you for going over all of those very insightful and informative. And while you all were talking, we had some questions come in. And then also, if anyone has additional questions, please drop them into the chat to me, and I'll make sure we address them. But I'll start off with the ones that have already been submitted as we've been going through our presentation tonight. So the first one is actually for Rebecca. So it says, since there is some overlap in what modalities can treat, how do you know which is the most appropriate for a client? And can some of the modalities be used together or complement each other?
Mm-hmm. Yeah, this is such a great question. I love this question, because, for example, just, going off what Maddie was saying about EMDR, that is an evidence-based trauma treatment. There are also other evidence-based trauma treatments, right? And so these don't have to be a competition. They don't have to be all or nothing, right? There's a way to find what's the best fit for you rather than what's the best fit, period. And I think that's really what's important when somebody is navigating treatment. So, I want to say a few different things about this. One is going back to the beginning of what I said about, therapy has to feel like dating in the sense that it has to be a good fit on both ends, right? So it has to be a good fit for the therapist in terms of them feeling able and competent to treat what you're coming in for. And it has to be a good fit for the client because this is somebody you're going to, tell your deepest, darkest secrets to, presumably, right? And you want to feel comfortable and safe with that person. So, for example, while I utilize various CBT strategies as my interventions, my style of intervention has a lot of active feedback, a lot of collaboration, humor, a bit of irreverence, right? And so therapists provide different interventions, but also have different styles. And so if a more active, irreverent style wouldn't be the best fit for you, then I won't be the best fit for you, right? And I take no offense at that, right? It has to feel like a good fit on both ends to know what's going to complement you most. Research consistently shows that what matters more than any type of therapy you're doing is the relationship you have with your provider. So in my opinion, that really comes first. Secondly, I think it's really important to consider what the person is coming in for. For example, if a person is coming in with chronic suicidal thoughts, self-harm, or other life-threatening behaviors, I'm going to suggest DBT because DBT is the evidence-based treatment for self-harm behaviors, other high-risk behaviors such as that. The client can get to a point in their treatment when they can shift away from just DBT and integrate any and all of the other treatment modalities we talked about. However, they, in terms of a treatment hierarchy, they have to address those life-threatening behaviors first. So the way I think about it and encourage everyone to think about it is to focus on the hierarchy of treatment goals and choosing what intervention might be the best first fit. What makes me really sad is the notion that we have to tell people there is one best. It is true that there is research and evidence to support that certain therapies are more effective for certain populations or certain presenting problems. I think many of the interventions we discussed today can complement one another, and improve overall treatment outcomes. However, I will say that doesn't mean somebody should be doing them all at once, right? We want our clients to be people first and foremost, and we don't want to overwhelm someone with multiple therapy modalities at once. It leaves very little time for other things, and it's okay to assume they're going to get there over time.
Thank you, Rebecca. And I love when you mentioned the research supporting the importance of the relationship. All 5 of us like bobbed our head yes. And so that's so true. And it looks like Marlo, your hand is up. If you want to unmute yourself and ask your question, that would be great. Maybe. We will come back to you. I'll check back in one more time with you, Marlo.
Yes, I'm sorry.
Well,
I'm still figuring out this thing. So I was familiar with some therapies. Well, actually just one, CBT, and I also heard of others. Some others you mentioned here I didn't know about. But the other question is, what insurance do you accept? Do you accept insurance, or you're off network with insurance?
Yes, for this question, you can check out our respective practices websites that I will have like insurance information and fee information and ways of contacting us. And we will send out a follow-up email from this panel that will have all the ways of contacting us. And I'm sure we'll be able to provide more specifics. I know that our practice, myTherapyNYC, accepts Blue Cross Blue Shield. I'm not sure about MindWell, but we can definitely get that information to you.
Yeah, and I'm happy to just quickly volunteer. We are an out-of-network provider. And so it would be based on sort of what your insurance reimbursement is.
Okay. So what about this other therapy that I wanted to ask you about, because I didn't hear it? It's called Schema. Do you offer it at all, or?
Yeah, so schema therapy, are any of the 4 of you familiar with it or could speak to it?
Not that much. Like, I was trying to find information about it, but I would like to hear from you.
Yes, Marlon was asking the 4 panelists if any of them know.
I'll say I know a little bit just about the basic theory, but no one at our practice sort of specializes in schema therapy. So I would feel like I was doing a disservice to it to represent it in its entirety. Unfortunately, it's not an intervention that we offer at MindWell.
Awesome, thank you. And it looks like Caitlin, if you would like to unmute yourself and ask your question, the floor is yours.
Yes. Okay, you guys might have went over this already, but I just need to clarify it in my head. What is the difference between DBT and CBT?
Yeah, Rebecca or Kylie, would you like to chime in on that?
Yeah, Kylie, you want to take this one?
Sure. So it's a great question. And I think it's goes back to Rebecca's initial point about CBT being more of an umbrella term, right? There's lots of different types of interventions that draw from cognitive behavioral therapy, and DBT is one of them. Something that, again, is specific to DBT is the sort of focus on more high-risk behaviors like suicidality, self-harm, where we're targeting those types of behaviors at the outset. DBT also tends to be more structured in nature than CBT. So it follows a specific treatment protocol, but it does fall within and under that CBT umbrella. But that's a great question.
Awesome, thank you. We have some more questions in the chat, but also if things come up, please feel free to raise your hands. So the next one we have is actually for Maddie. The person is wondering, are these modalities appropriate for all ages?
Great, yeah. So I would say generally, yes. Most of these modalities have kind of adaptations that are made specifically for adolescents or children. And maybe Rebecca or Kylie can speak to that a little bit more, because I know your practice does also work with younger clients. But speaking to EMDR and relational therapy specifically, EMDR has been researched with adolescents and children, and it has been found to actually be extremely effective in processing trauma, especially because of kind of the neuroplasticity and how EMDR works with that. So when you're working with such young minds, it's typically very easy to kind of go in and restructure some of these like negative cognitions or negative self-beliefs, just because there's not a lot of like attachment or a lot of kind of like sticky stuff that these beliefs can get stuck to, because you're young and you don't actually have that many memories for them to get stuck on. And then speaking to relational therapy, again, working on building relationships with the clients is such an important part, helping younger clients understand, their context and check in with kind of how identity and personality and things interplay with mental health, especially at young ages. So much of that is being developed, your sense of self. And so to have somebody supporting you with that is as excellent. So yes, yeah, I would also say that you would want to work with a therapist who's trained in working with adolescents or younger clients. And then obviously with adults, most of these would be good, especially just depending on what you're hoping to work on. But yeah.
Thank you. And Rebecca or Kylie, did you want to add anything to that, or do you think Maddie pretty well covered it? We're good? All right. All right, looks like we have 2 more questions unless any more trickle in. So this one is for Kylie. What are some other popular modalities that we didn't discuss today?
Yes, this is a really good question. So if you're in the process of looking to get started in therapy, you might come across a number of different treatment modalities that we didn't discuss here tonight. I would highly recommend in your consultation asking a prospective therapist or clinician more about their therapeutic orientation and sort of how they might utilize that in treatment. Again, getting a good assessment for what might be a good fit for you and sort of your presenting concerns and sort of what your goals are in seeking therapy. So a couple examples that you might notice or see sort of out there in terms of treatment modalities. This might include specific types of family therapy, like structured family therapy or internal family systems therapy. There are therapies like narrative, music, dance, drama, art, and bibliotherapy. You might see psychodynamic and psychoanalytic therapy as a modality. There are brief short-term therapies like solution-focused therapy. For couples, there's emotionally focused therapy and something called the Gottman method that you might see. There's Gestalt therapy, humanistic therapy, things like cognitive processing therapy, play therapy, motivational interviewing is another one you might see. And then some other treatment modalities like biofeedback or neurofeedback. So those are just a couple of examples of different modalities that you might see. Again, I highly recommend, a lot of clinicians will offer the opportunity for a phone consultation, and this is a really good time to ask more about their orientation and what kind of modality that they pull from in their practice.
Thank you so much. All right, looks like we actually one just came in, so now we still have 2 more. So one thing that I'm sure we've all become accustomed to is like in this new, or unfortunately not so new world anymore with being virtual, kind of, I think all of our practices are hybrid, where some is in person, some is virtual, and like kind of are there major differences in that? So one person wants to know for Jonathan, like what should we know about if there are any significant differences between virtual or in-person therapy?
Yeah, it could not be a more timely question in the world that we're living in. So, as we acclimate back to a world that involves going back to work, socializing again, if you're starting or restarting your therapeutic journey, you're going to wonder, do I want to do in-person? Do I want to do virtual? Regardless of what therapeutic model, the ones that we discussed or the ones that Kylie just shared, you might also come across as well. So some things to consider if you're thinking about starting virtual therapy is 1, privacy. So do you have a space where you can speak openly and freely with your therapist during your therapy session? Could being in your own space or on your computer or phone pose a distraction? So that could potentially inhibit you from getting the most out of each session. On the other hand, a pro for virtual therapy is some people may feel it's easier to be more vulnerable in their own space. One may be less self-conscious about what they're wearing or their body language if only you're seeing, the shoulders up and above shown on the screen. And, logistics and convenience is definitely a factor with virtual therapy. So living in New York, many people are still working their jobs in a hybrid model. So virtual therapy, I've seen a lot with my clients, has made it more accessible for a lot of my clients to consistently attend therapy sessions without having that long commute. So, a 45-minute session could turn into 2.5 hours in New York if you're going in person, depending on where you live and where your therapist's office is. And finally, virtual therapy is beneficial for people with physical disabilities or mobility issues, that they can have more accessible care where they may not have to physically go somewhere. In contrast, in-person therapy may provide a safe place to talk through topics that could be influenced by housemates, romantic partners, or family members that you share a space with. Having this separate physical space than where you live, or now most of us are working from, may help set the tone for practicing mindfulness and being more grounded before and during your therapy session. There's also a lot less to be distracted by in your therapist's office, since your personal items or certain things that could be impacting you are not there. So this neutral space, rather than your home or your workspace, could be more soothing for you to get the most out of therapy. Finally, another positive to in-person therapy to consider is that your therapist is able to see your full self, which might provide some insight or curiosity with nonverbal communication or body language that is missing through virtual therapy. And you may be also able to feel the connection or energy between you and your therapist in person that may be harder to tap into through a screen. But overall, there are pros and cons that I just listed to virtual and in-person therapy, but they both can have many, many, many therapeutic wins and successes. So I hope whichever path you go down or considering, it's not really like one is better or best. We're talking about therapy as this whole of what works best for you. And we're seeing you as like a whole person of, you have travel things to consider. You have other life factors, like if you're a parent or take care of someone else in your life where it might be easier for virtual, or you might find that the uniqueness and interpersonal connection with an in-person therapy session is more important to you, and you make those accommodations to make it work for you.
Thank you, Jonathan. Love those pros and cons. I personally am partial to virtual. I love having my dog on my lap and being in my sweatpants, but to each their own. So it looks like we have one final question. I think anyone could answer this, but maybe Kylie, because it seems to be overlapping with DBT a bit. So aside from talk therapy, do you use arts or activities to boost self-esteem, anger management, or stress reduction skills? If so, what are some examples of that? And also, didn't mean to put you on the spot, Kylie, but if anyone has any insights as well.
Definitely. One that comes to my mind right away is the use of art in therapy. And specifically drawing, as well as writing. So I think I tap into those two sort of creative forms all the time in therapy, whether that be in a CBT session or with my DBT clients as well. I think really trying to think collaboratively about what types of activities really help them to utilize mindfulness. That's something I'm thinking about a lot in our sessions, is how can I help my clients to sort of utilize their mindfulness skills? And I think art and creativity are a really excellent way to do that. So that's certainly one. In addition to other sort of emotion regulation skills, we think a lot about activities with respect to regulating emotions, whether that be getting movement, attending to sleep, all kinds of other activities that we know are either mood boosting or sort of help us to utilize those skills more effectively. So yes, I would say a lot all the time, as much as possible, thinking about not just sort of those activities, but if a client has a particular interest in a certain type of expression, be it creative or artistic, I'm thinking that throughout.
Great. Well, I think that is about it. We don't have any more questions. I think we covered a ton of ground tonight. So I want to give a big thank you again to Maddie, Rebecca, Jonathan, and Kylie for all of the wonderful insight and information you provided us tonight. And also a big thank you to our practice, myTherapyNYC, and also your all practice MindWell for the collaboration. This was wonderful. I hope we can continue to work together. And just one logistical item for all of you in attendance, we will be following up with an email later this week that will also have the contact information for our practices. So if you have any further questions or are interested in treatment, please feel free to reach out. And I think that's about it. So I hope everyone has a warm, dry, and safe night. And thank you for coming.
And thank you, Andrew, for moderating.
Thank you, Andrew.
Thanks, everyone. Have a great night.
Thank you. Take care.